Log in to KofiPaisaTV.com and get Spears of the Mossy Volume 1 by Kofi Paisa Research Team. From Spears the Pen Volume 2 by Kofi Paisa Research Team. Spiritual Combat Volume 3 by Kofi Paisa Research Team. One Night Before Bed by Any Harret Sean Calfunny. Kalawa's Trip to the Motherland by Kofi Paisa. From Cocaine to Consciousness by Any Harret Sean Calfunny. As I learned, we all learn by Kofi Paisa. Also, if you want fresh merch, go to our online store, Family Connect Apparel, and get all the brands. Also, get our 54 deck of quiz and educational cards available now on KofiPaisaTV.com.
ETM Hotel, Rennie Sean, welcome in peace. My name is Sean. I'd like to thank everybody for tuning into another episode of Science of Sean. We are back, and we're going to deal with infertility, COVID-19 vaccines, and pregnancies. Because that is data that will be coming down the pipeline sooner or later regarding women and vaccines, with mRNA vaccines. We're going to see if a lot of questions will be answered. How pregnant women will do in these trials. Will the child at birth, will the child inherit antibodies, right? Will this be innate? Those are pivotal in dealing with COVID-19. And I think that we need to pay attention to those things. Appreciate people coming into the building. Peace, Teddy, Robert Rand, Juju. The other people that are tuned in but haven't commented yet, peace to you. Like the show, share the show. Right, like the show, share the show. And let's cook. So before we get started, I do want to begin the build with podcast. From JAMA regarding coronavirus vaccination in pregnant and breastfeeding individuals. Now, the link to this is actually in the description. This is from February 8th. I do want to play about a few minutes of it just to let you guys get into why I am even talking about pregnant women and vaccines. So as people are coming in, please like the show, share the show. We're dealing with COVID-19 vaccines and pregnant women. And if these mRNA vaccines are causing infertility, that is one of the claims that is roaming out there. So let me go ahead and share my screen. And let's have some fun.
From the JAMA Network, this is Conversations with Dr. Bachner. Interviews featuring researchers and thinkers in healthcare about their publications in the latest issue of JAMA.
Hello and welcome to Conversations with Dr. Bachner. Once again, it is Howard Bachner, Editor-in-Chief of JAMA. And I'm delighted to be joined by two preeminent physicians, both who work in obstetrics and gynecology. Denise Jamieson, formerly of the CDC, was named the James Robert McCord Professor of Gynecology and Obstetrics at Emory and Vice Chair for Population Health in 2017. She's currently Professor and Chair of the Department of Gynecology and Obstetrics. Welcome, Denise.
Thank you.
And my other guest is Kathy Spung, and Kathy was at NICHD, and she's now the Gillette Professor of Obstetrics and Gynecology at UT Southwestern. Welcome, Kathy.
Thank you.
We're going to talk about a pair of viewpoints that are being published simultaneously with this presentation. And Denise, why don't we start with you talking a little bit about your co-author, Sonia, The title of your JAMA Insights is Caring for Pregnant and Postpartum Individuals During the COVID-19 Pandemic.
Sure. Sonia Rasmussen is a dear friend and colleague. We've known each other and worked together for almost 20 years now. She is a professor of pediatrics. She also has an appointment in OBGYN and in epidemiology at the University of Florida in Gainesville. She and I at the CDC really worked together to try, starting with pandemic influenza, to try and plan for what to do about pregnant women when there are novel pathogens, emerging pathogens, to try and figure out how pregnancy issues should be handled. And so we worked together on pandemic influenza, and then Ebola, and then Zika. And then we both left the federal government. We were at the CDC together for many years and continue to collaborate on COVID-19.
And your experience about flu and flu during pregnancy as a vaccination, we'll talk about that in a bit. Kathy, your co-authors, Emily, COVID-19 vaccination in pregnant and lactating women. Can you say something about your co-author?
Yeah, so Dr. Emily Adhikari is an assistant professor here at UT Southwestern, and she's also the medical director for perinatal infectious disease at Parkland Health and Hospital System. And she is the go-to person for COVID-19 here at UT Southwestern and at Parkland, and has been on call 24/7 since the pandemic began, really caring for the sickest of our sick and really navigating the incredible onslaught of COVID that we've seen on our very busy labor and delivery service.
Before we get to vaccination, let's talk about a few other issues that actually are really important to inform the potential of vaccination of pregnant persons. So either of you, and we'll alternate back and forth, what do we know about the risk of COVID-19 for pregnant persons, the fetus, and the newborn? So Denise, why don't you go first?
So I like to think about pathogens for the mother, for the maternal risks, in terms of susceptibility and severity. And in terms of susceptibility, how transmissible to pregnant women is COVID, we really don't have any information. We know that the same risk factors that put people at risk for acquiring COVID are the same, whether you're pregnant or not pregnant. But we really don't know whether pregnant women are more likely to get COVID. What we do know is that once pregnant women get COVID, they're more likely to have severe disease. They're more likely to be hospitalized, to require intensive care, to require ECMO, to be ventilated, and to die, unfortunately.
The fetus.
In terms of the risk to the fetus, we know that there seems to be an increased risk of preterm birth among women who are infected with COVID. There may be an increased risk of stillbirth. I think.
Okay, to all the ladies that actually watch Science with Sean, I want you to pay close attention to what's being said right here. I'm gonna run it back because this information is vital in actually understanding. Now, some of you may not be having kids. Some of you may have kids in the future. I don't know, right? But this is a learning experience, and I just want y'all to know what's going on. So I'm gonna go back and I'm gonna let her get into it again. And I want y'all to hear what they are specifically saying about how COVID, not a vaccine, but how COVID is interrupting this whole childbearing situation.
Actually are really important to inform the potential of vaccination of pregnant persons. So either of you, and we'll alternate back and forth, what do we know about the risk of COVID-19 for pregnant persons, the fetus, and the newborn? So Denise, why don't you go first?
So I like to think about pathogens for the mother, for the maternal risks, in terms of susceptibility and severity. And in terms of susceptibility, how transmissible to pregnant women is COVID, we really don't have any information. We know that the same risk factors that put people at risk for acquiring COVID are the same, whether you're pregnant or not pregnant. But we really don't know whether pregnant women are more likely to get COVID. What we do know is that once pregnant women get COVID, they're more likely to have severe disease. They're more likely to be hospitalized, to require intensive care, to require ECMO, to be ventilated, and to die, unfortunately.
The fetus.
In terms of the risk to the fetus, we know that there seems to be an increased risk of preterm birth among women who are infected with COVID. there may be an increased risk of stillbirth. I think the jury's still out whether or not there's an increased risk of stillbirth. So basically, we know that particularly among severely ill pregnant women, their babies don't do as well. And that's the same as in most pathogens.
Kathy, do you read the literature and reach the same conclusions? And it's not to create a debate, but sometimes it's confusing literature. JAMA's actually published an extensive number of research letters and other types of articles. Is your reading of the literature the same as Denise's?
Yeah, so I do read the literature, and
Oh, I know.
and in fact, we have Dr. Adhikari's first author on a JAMA Network Open paper specifically related to our experiences with COVID in pregnancy. And we have a slightly different population that is published in other reports because ours is more of a population-based publication rather than just those who are hospitalized. So what we found was that women who had COVID-19 in pregnancy had about the same rate of hospitalization if they were pregnant or not pregnant. So it was about 5 to 6% required hospitalization. Now, I will say that those who have severe or critical illness, we also found a much higher rate of preterm birth. In fact, I think the literature is about 10 to 40%. We found about 60% delivered preterm. I will say that it is hard to know for certain that impact on the fetus. There certainly have been case reports of vertical transmission. The vertical transmission that we have seen has been predominantly from asymptomatic women. And I think, it's difficult to discern whether or not pregnancy itself increases your risk, but clearly women with critical illness have much higher risks when they're pregnant.
Now, Denise, around Zika, it was very clear we were seeing adverse effects on the fetus and the newborn. Is the data less clear around COVID-19?
So with Zika, there's clearly a congenital syndrome. First of all, Zika was more easily passed transplacentally. As Kathy was saying, there are cases where SARS-CoV-2 is transplacentally infecting fetuses, but it's much less common than with other pathogens such as Zika. And interestingly enough, people don't realize, but even influenza can be passed transplacentally. Almost all viral infections under the right circumstances can be passed transplacentally. But with COVID, it doesn't happen very often. And so with Zika, you got a congenital syndrome. It was a very specific pattern of abnormalities that was noticed fairly early on in South America. By contrast, we are not seeing concerning patterns of either frequent congenital infections or a congenital syndrome. So I don't think that that is likely to be, with all the women that are now infected, all the pregnant persons that are now infected, I think it's very unlikely that we're going to see a specific congenital pattern.
Now, Kathy, your department oversees quite a few births. You mentioned 40,000 before we started. I knew it was large. I didn't know it was quite that large. Questions keep coming up around the peripartum processes and protections that need to be put in place. So for a woman who comes in to deliver, you screen them and they're generally healthy and they're COVID-19 positive. What are you doing at your institution?
When a woman comes in, every woman who's admitted to labor and delivery is screened with questions and then all are tested. Those who are symptomatic are initially put into an isolation room and all of the protective gear is used for each interaction. Some will come back as asymptomatic COVID positive. And again, you will take those extra precautions. As long as they are asymptomatic, they are allowed to room in with the baby and do all of the normal things.
Breastfeeding,
absolutely.
And for those that are symptomatic, what happens if the mother is symptomatic at the time of delivery and presumably the baby's well?
So that's evolved over time because, we had to learn how risky the transmission was. And I think that that's also come out with some of the publications looking at the risk of transmission with breastfeeding, and that in fact it's very low as long as the mom is very cautious and careful and does good hygiene and wears a mask to try to reduce that risk of transmission. So it has definitely evolved over time.
Denise, the same question to you, the symptomatic, asymptomatic woman who's been admitted to Emory and is delivering. How do you deal with both the asymptomatic person as well as the symptomatic person?
Almost identical to what Kathy described. So we test everyone now. If they're positive, we make sure that everybody in the room, all the healthcare providers in the room, have a N95 mask, that the patient is masked, take all the usual precautions. And then, like Kathy, our thinking has also evolved over time. And based on basically a fairly large case series from New York City, where infected moms safely breastfed their infants using careful hand and breast hygiene, masking with every contact, we now know that the babies can remain safe even with breastfeeding and moving in. The only other thing they did in New York City that I thought was interesting in the case series that was reported is the infant stayed in a closed isolette rather than an open isolette. That is not something that we have done, but I thought that detail was interesting.
Yeah.
One question already came in, and then we'll move quickly to vaccines, because I know that with 3.8 million births a year, and WHO's announcement and then change, it's on everyone's mind. Do either of you at UT Southwestern or Emory, are you testing for vertical transmission or not normally?
So it's not routinely done. If an infant is experiencing any symptoms, then we will test, but it is not routinely done.
And when you do that, how do you test, or what do you test for?
Yeah, so if there's a suspicion, then the babies are tested. So they generally do a full workup with oral pharyngeal swab, cord blood. The pediatricians do a full workup of the baby.
So now let's go to the question that everyone keeps asking me. And since I can't answer it, I've asked the two of you to come on the program. I appreciate that there's no definitive answer, so I'm willing to begin the conversation that way. Kathy, how do you think about advising pregnant persons about being vaccinated, and which vaccine, the timing of the vaccine? Would you avoid the first trimester? Would you tend to get it in the second trimester? For people who anticipate trying to get pregnant next year, would you really try to get those individuals vaccinated? How do you even think about this?
The difficulty, and the reason you're asking the question, is, of course, because neither pregnant nor lactating women were included in the studies
Correct.
of the vaccines, right? And so without that data, then how do you decide what to do, given what we know, that pregnant women, certainly with severe disease, have very, very high risks, both for herself and for the baby. And so how can we mitigate that? And even though they were not included in the studies, both the FDA and the CDC's Advisory Committee on Immunization Practices left open the door to allow pregnant women and lactating women access to the vaccine. And the American College of OBGYN and the Society for Maternal Fetal Medicine have been advocating that pregnant women should have access to the vaccine. And I think, it's really important that you consider what is the risk to the woman of COVID-19. So in an area where there is active transmission and she is in a high risk group, she should certainly have access to that vaccine. And we are offering all of our women in our maternal fetal medicine clinic the COVID-19 vaccine and making certain that it is available to them because of those risks.
Denise, you were at the CDC. You're one of the world's experts on influenza and vaccination during pregnancy. How have you thought about this?
So I review all the same information that Kathy does, but I also emphasize that there are real and meaningful risks of not getting vaccinated. And so if you're a healthcare worker and you would otherwise receive the vaccine if you were not pregnant, then I am fairly supportive and a little bit more directive about the fact that I think the vaccine is a good idea. Flu vaccine was so different because the Surgeon General first recommended flu vaccine for pregnant women in 1960. We had many decades of experience, and we had a little kerfuffle with trying to figure out whether we should be offering in the first trimester.
Right.
But as it turns out, regardless of trimester, women should receive the flu vaccine. So I think about all the years of maternal vaccination and immunizing pregnant women, and I think that it's likely that in the end, the benefits will greatly outweigh the risks, any theoretical risks, none of which we've seen yet.
I absolutely agree with Denise. I too am incredibly supportive and encouraging. The difficulty is this nuance that we have to walk through.
So if a friend or a relative calls you and goes, I have a pregnant person in my family, and that person is asking me if they should be vaccinated, would you tell them yes, wait until the end of the first trimester, or would you say if they can get vaccinated, they should get vaccinated? Kathy, I'll go with you first, and then I'll let Denise think about what she's going to say while you answer first.
Absolutely. So I will talk with them first about vaccinations in pregnancy. As Denise mentioned, we do this commonly. We recommend them. We have shown that it improves both maternal and fetal outcome. Influenza, pertussis, whatnot. We've got data to show that vaccination is commonly done. I will talk with them about this type of vaccine, the mRNA vaccine, that you cannot get COVID from the vaccine itself, that it is immunogenic, it is not infectious, it is not an integrating vaccine, right? So we have knowledge about this type of vaccine. And then I'll talk with them about the risk of COVID-19. Clearly, we see across the country, it is a significant cause of morbidity and mortality. And if you get severe COVID-19 in pregnancy, your risk is very, very high. So yes, I will go through those things and say vaccination has the potential of preventing COVID-19, which would be beneficial for you and for your pregnancy. And I would not differentiate by trimester.
And Denise, you get the same telephone call?
I counsel in much the same way, except I have to say I take into account practical considerations as well. So if you're a healthcare provider and today your health system is offering you the vaccine, think really carefully about declining the opportunity to get vaccinated, because that same opportunity may not be available next week or next month. And so I really think that delaying, given that we have not even theoretical concerns about the vaccine, may carry a heavy cost, not to mention as long as rates of transmission are high. If you're a healthcare worker in a healthcare setting, you're at risk every day. So I would advise to get vaccinated soon and not delay, regardless of trimester.
Absolutely. If I can add into that, I think it was a recent conversation that you had with Dr. Fauci, where he talked about that since that emergency use authorization went into play for the two vaccines, that over 10,000 pregnant women in the United States have been vaccinated. And to date, there have not been red flags. So that is also reassuring, I think, in that conversation.
Denise, for people who are not in the high risk category, age or other comorbid conditions, an essential healthcare worker, are vaccines available in Georgia for pregnant persons?
Not unless they're healthcare providers. In some prioritization schemes, they're in the high risk medical conditions category. Pregnancy is included, but not available yet.
Kathy, and in Texas?
So at UT Southwestern and at Parkland, if you are pregnant and you're at high risk, and so our maternal fetal medicine clinic kind of encompasses that, they are getting vaccinated.
It's so interesting to see the variability across the country. 50 states, District of Columbia, Puerto Rico. I've always wondered if we would have been better off with kind of a singular approach, but I fully recognize that we still live in a country with states' rights. Just to follow up on vaccination, a number of questions have come in. Right now, it's only Moderna and Pfizer, both mRNA vaccines. I think we can anticipate that the J&J and adenovirus vector vaccine will be approved sometime in February. Is there any reason to think about differentiating between vaccines?
Between Moderna and Pfizer, I do not differentiate between them. And I appreciate that the WHO really kind of called that question, right? When they put out their report on the 26th saying that pregnant women should not be vaccinated with the Moderna vaccine. But there was no additional data to support that. And on the 29th, they reversed that stance, that pregnant women who are at increased risk for COVID-19, as an example, as Denise said, healthcare workers should be offered the vaccine. So I do not differentiate between the two. I think I'm going to have to wait to see when J&J comes out to determine that.
Denise, any sense of the different vaccines are similar to Kathy?
The adenoviral vaccines are interesting in that same platform has been used for Ebola vaccines. And I don't know if you remember, but we went through the same thing with Ebola, where pregnant women, even in high-risk spots in West Africa, were excluded from vaccination efforts. Many pregnant women ended up getting inadvertently vaccinated, and then they were added into trials. And so we do have more data on the adeno platforms in general than we've had on the novel mRNA vaccines.
Can I assume they were safe?
Yeah, they were safe. So again, in the absence of any theoretical or real risks, I'm not sure how we're going to decide whether or not to differentiate on the basis of safety for pregnant women.
Now, both of you are members of numerous professional societies, particularly professional societies being queried about vaccination during pregnancy. So, Kathy, again, I'll start with you. What are your professional societies saying about vaccination during pregnancy?
So both the American College of Obstetricians and Gynecologists and the Society for Maternal Fetal Medicine are advocating for making COVID-19 vaccines available to pregnant and lactating women. The exact verbiage differs slightly, and I think Denise really outlined that nicely in her viewpoint, where she put side by side the different recommendations, and some are more positive and some are more negative type statements, should not be withheld versus should be offered.
A question to both of you, because it came up, that Phil Fontana Rose and I edited both of the two pieces, and Ed Livingston helped on the Insight piece. Everyone always wants a child to be born healthy, and legal liability always comes up. It's such a difficult issue for obstetricians. I'm a pediatrician. I've delivered a number of infants, but it's so difficult for obstetricians and families who really want a healthy child. And so we have these vaccines. mRNA it is limited use before this. It was interesting, Denise, I hadn't realized that Ebola also had an adenovector vaccine. How do you think about the notion of legal liability when you're trying to talk with families or you're going to give the vaccine and you're nervous about it? Denise, how do you think about that?
I think it comes down to the same risk-benefit analysis. When COVID is circulating widely, there are real risks to not getting vaccinated. We know the risks of being infected with COVID. And if the mother doesn't do well, the baby's not going to do well. And so to me, I think it's just a risk-benefit analysis.
Kathy?
I absolutely agree. With respect to these vaccines, it's a risk-benefit of what's your risk of COVID, and getting the vaccine is going to markedly reduce that risk. I think the idea and the concern about liability is why the pregnant and lactating women were not included in the studies or in the trials. That's the major reason, right?
Has it been your experience, and it's always hard to generalize, that for pregnant persons, they tend to want the vaccine because of the concern that they could get infected and the implications, or they don't want the vaccine because they're nervous about introducing something that could threaten the health of the fetus? Or is it hard to generalize?
One thing I'll say is that pregnant individuals often feel very passionately one way or the other, and there's very little middle ground. So you have particularly pregnant healthcare workers who are at the front of the line clamoring to get vaccinated. And then you have another group that's very concerned and really is very hesitant to do anything that they perceive might adversely affect their baby. I think one of the other things that's really important is, just because we're saying we think the benefits outweigh the risks, that doesn't let us off the hook in terms of describing the risk. And I think that's one thing that I'm concerned about, is that 15,000 pregnant persons have been vaccinated, and yet we really have stunningly little safety information, and that's not okay.
Kathy, what's been the experience at your institution about families wanting to be vaccinated or passionately concerned about the risk?
It's a great question, and I think Denise summarized it very well. I will say that it's not only with the COVID vaccine, we get the same question with the flu vaccine and with Tdap. And education is really critical in talking about what are those risks and why you might want to get this vaccine. We're capturing some of this information actually in our patients, trying to understand, are they willing to accept the COVID vaccine or not, and trying to get at some of that nuance and looking at, did they get the flu vaccine as well? Is this a person who just is not interested in vaccines? Do they understand what type of vaccine it is, that in fact there is no virus that is entering your body? You cannot get COVID from this vaccine. And so those are all things that are part of the education process. I think the other piece that's really important about it is the discussion with her about the side effects, because those side effects, when they occur in pregnancy, could be very concerning, right? And so trying to reassure that these are side effects and these are reasons why we want you to return if these things happen. So I think it's really important, that education piece, when you're talking about the COVID vaccine and any vaccine.
Not surprisingly, there are many questions. If a pregnant woman recovers from COVID-19 from a mild case in the first trimester, what would you recommend for follow-up? And I'm assuming the corollary of that question would be, say they are infected in the first trimester, it's now the second trimester, would you recommend that they get vaccinated? So follow-up for someone who's infected during pregnancy, what would you recommend?
So the good news is that it seems that the biggest risk is infection and illness closest to the time of delivery. So the good news is that if you're infected in the first trimester, we would anticipate that you would do fine. I would still recommend that you get vaccinated even with prior infection for a variety of reasons.
Absolutely. Your follow-up care is going to be similar to if you had not had COVID during pregnancy, but I think both Denise and I would recommend that they get vaccinated.
All right, so this is a conversation that we should really be having or be a part of, right? Because we're talking about vaccinating pregnant women. That's what this whole show about. We talked about it the other day with the Pfizer and BioNTech trial, right? People can sign up, pregnant women between the ages of 18 and whatever, 18 and older. Trials have already started. They're signing up more people. And they're trying to have that data by the end of the year.
For what? For Pfizer, yo?
Yeah.
For pregnant women? What?
Yep.
Go ahead. How you doing, brother?
I'm doing fine, Unc. Welcome to the show. Appreciate you have joining us. We know you're pretty busy.
Yeah, yo, to be on the Science for Sean, though, yo. It's my shit right there, yo. So I listen to you all day, every day, bro. For my latest updates. Proper science. And I would like to also congratulate you on the conversation with the pseudo doctors. They be slipping, yo, a little bit there. Caught them slipping. But now this is because we talked to a pregnant. We was talking to somebody about anyway, man, like real fast, yo. I ain't gonna talk you to death. I'm gonna say this. People
go ahead.
I've heard it before. What you said before that, all vaccines are constantly being monitored forever. I remember you saying that. And so people have a problem with it.
Yeah.
It's almost like they take it before you take the vaccine. And I be trying to tell them that chemicals, and not even the chemicals, just the stuff they use in vaccines, like they started that process years now. So they pretty much know what those products are going to do in human beings. And the thing that they always forget, you could sprinkle some salt on your food for years to survive. And then drink a whole cup of die. So the amount of something is what makes it poisonous. So these vaccines, they understand them. You feel me? And at no point would they allow human beings to put a vaccine in them that's more dangerous than the pathogen it was created for. So I just wanted to say that. Like, people keep missing the whole thing, that the pathogen, the infectious virus, is triple, quadruple times more harmful than any vaccine. So, I think we just up against it. Hey, you know what I mean? You got black doctors talking crazy. You got black doctors using sources. We ain't even gonna say what source they use. We're gonna wait till we see them again and show them. And say, y'all, this is y'all do time. Really?
So the reason why I'm doing this is because of the infertility claim.
Oh yeah, man. Yeah, man.
Saying that you get the vaccine, you're gonna be able to have kids.
Yeah, they just say anything. Where's that long-term research? How did they come up with that research that quick? How about that? How did they know that fast? See, I'm gonna do the same thing you do that. How do you know that quick? How y'all know? How'd y'all figure that out? So if you can figure that out, then you may figure out whether it's gonna get you or not. Huh? But go ahead, Sean. That's fine.
Nah, I was just saying. So I got like a couple minutes left in this this bill, and then I wanted to transition into the article that I had on the screen. So I'm gonna let it play a minute. I know you're walking in the crib. And now let's just get situated. I'll run this while you're getting situated, and then we'll get into the articles and you tell me what you think.
All right, go ahead.
All right.
Anticipated safety of having vaccinated relatives visit or help with the newborns?
And that's an interesting question about this whole concept of cocooning, that you want to make sure that who's ever around your infant, when the infant is too young to be vaccinated, that they're protected. And if you're going to have people in the house helping with the newborn, it's a great idea to have them fully vaccinated and several weeks after, in the case of mRNA vaccines, several weeks after their second vaccination.
And I would still encourage them to adhere to all of the practices that you want. Just because you've been vaccinated doesn't mean that you should no longer wear a mask or do good hand hygiene. Continue those practices, because we all know that the vaccine is not 100%, right? And so it's really, really important, even if vaccinated, that you continue to adhere to all of the precautions.
And unfortunately, we don't know about the role of variants either.
Yes, I had a chance of talking with Tony last week, and I think we're both guardedly optimistic in the next couple months is that the numbers have really come down dramatically in the US. And we had 130,000 admitted to the hospital as much as a month ago, and now it's down to about 80 or 85,000. And obviously, the deaths have come down. The deaths relate to the number of people hospitalized, and more people are getting immunized, 1.3, 1.5 million a day. But the real issue is, what do the variants ultimately mean? I'm not quite sure they'll play out that quickly in the US the next 6 or 8 weeks, but beyond 6 or 8 weeks, they may really impact how we think about which vaccination and the timing of vaccination. Any risks to a breastfed baby if the mother gets vaccinated?
The data has not shown that there is a risk to a breastfed baby from mom being vaccinated. In fact, the American Academy of Breastfeeding Medicine fully supports breastfeeding and anticipated that the vaccine would not transmit into breast milk. And even if it did, it would be digested by the baby and not enter the babies.
For the individuals who are admitted to the hospital at the time of delivery and are COVID-19 positive, are those pregnant persons being allowed to breastfeed?
Yes, absolutely.
Okay.
The other thing to mention about postpartum vaccination among breastfeeding women is we give a live viral vaccine, measles, mumps, and rubella, to pregnant women who are breastfeeding routinely. So the whole fact that pregnant and lactating women get lumped in together really doesn't make any sense.
Denise, both of you have been at this a long time. I mean, Kathy, you were at NICHD, and Denise, you were at the CDC, two preeminent institutions. Is it disappointing that somehow pregnant women were once again excluded from these trials?
Absolutely.
Absolutely. If you look over the last several decades, there have been huge groups that have worked towards including pregnant and lactating women in research, in clinical studies. In fact, Congress, of course, proposed and passed the Cures Act, which included PREGLAC, the task force for including pregnant and lactating women in clinical research. And that task force met for years and came up with recommendations on how to include these two groups in clinical studies and trials, and then went through another cycle to identify how to implement those recommendations. And yet still, again, they were not included in something where clearly they are at high risk.
Denise, your comments about this, I'm sure, echo Kathy's, but I'm curious.
I agree. I think the other piece of this is really CDC's piece as well. I think now that we have thousands of women, tens of thousands of women vaccinated, we really need to beef up our surveillance of pregnant women who've been vaccinated and really learn as much as we can from the many women who are coming forward and getting vaccinated. And I don't think we're collecting that information nearly as quickly as we should be.
Do you know if there's any trials that are ongoing? We do know that trials for adolescents have begun, and then ultimately they're going to drop that down to prepubertal children. Do you know if there's any ongoing trials with pregnant women?
It's going to be harder and harder to enroll pregnant persons in placebo-controlled trials now that the vaccines are rapidly becoming available. So my hope for this vaccine and other COVID vaccines are that we really look carefully at observational safety studies. Be Safe, the CDC surveillance system, has a module for pregnancy, but I think we really need to enhance our efforts to very rapidly gather information about this vaccine in pregnancy. I think we owe it to pregnant persons.
Absolutely. I mean, this is the time for the proactive data collection to not only get at vaccine-related symptoms, but also obstetric outcomes, given that so many women now are being vaccinated, because we have to create that evidence base so that we can replace the expert opinion and give people the evidence.
I just want to return to a few more questions because I know this topic is so clinically meaningful to people. Can a caregiver who is fully vaccinated still carry the virus to a baby or a mother if she is not vaccinated? So I assume this question is really, a grandparent gets vaccinated, can they visit their pregnant person or the baby?
So it goes back to the previous question, right? Again, just because you're fully vaccinated doesn't mean that you can't get COVID-19, and the variants play into that role as well. So we cannot let our guard down, and it is critically important that we adhere to all of the masking and the hygiene and recognize that, yes, you could be asymptomatic and have COVID even if you were vaccinated.
Right. Lots of questions about passage of vaccine-induced antibodies via breast milk in the infant. Is it protective?
I don't think we know enough about the transplacental passage of antibodies and antibodies in breast milk and all the other issues. So we need more information. There have been some early initial studies, but we don't know nearly enough yet to be able to say. We hope so. We hope it's like influenza or pertussis, and that by vaccinating the mother while pregnant, you provide protection to the infant. Fingers crossed.
That's the hope.
Both of you, over your careers, have participated in studies, studied the issue itself about vaccination and pregnancy and the threat of illness during pregnancy to the fetus and the newborn. I'll start with you, Denise. What has struck you about COVID-19? When you look back over the previous year in your area of expertise, what have been the surprises?
When I was at the CDC doing emergency preparedness planning, we thought about respiratory pandemics. We thought about pandemic influenza. I did not foresee how completely this pandemic would affect every facet of our lives. And I think it's been really hard on pregnant persons and mothers in a way that I did not appreciate.
Kathy, when you reflect on now it's 14 months in the US, we're approaching 500,000 deaths. There's 3.7 or 3.8 million births a year. So we know this affects an enormous number of individuals as well as their related families. What's your perspective when you look back over the last year?
So there's a couple of things that come to mind. One is, before I get to the impact on the family, I think very interesting on the hospital system, where many elective cases, surgeries, things changed. Other services had a decrease in volume. In obstetrics, we certainly did not have that. In fact, in some ways, we had an increase in volume. And this gets into the family situation where COVID has impacted stress and mental health, and the role of the woman, especially in socioeconomically disadvantaged populations, is even higher. And you've now got perhaps someone who doesn't have a job at home. You've got the children at home. You need to educate the children, online schooling, all of that stress. I think I would not have anticipated that.
This is Howard Bachner, editor-in-chief of JAMA, and I've been joined by Denise Jamieson, formerly of the CDC. Denise is the James Robert McCord Professor of Gynecology and Obstetrics at Emory University. Kathy Spung, formerly of NICHD, and she's now the Gillette Professor of Obstetrics and Gynecology at UT Southwestern. I want to thank the two of you for joining me today. Pregnancy, immunization during pregnancy, pregnant persons, it's always emotional and difficult. There's never certainty. And I think that lack of certainty makes it a much more difficult discussion. And I want to thank the two of you, Denise, for your JAMA Insights entitled Caring for.
All right, so he's thanking them for that. So there's a 30-minute conversation that we just went through with three experts, pretty much. All right, you can find that in the link. And one of the things that was mentioned, and well, the overall consensus between the two women, right? And one's actually in Atlanta. Dr. Denise Jamieson. She's a And the other lady, where's the other lady at? The other lady's in Texas, Catherine Sponge, Dr. Sponge. Both were highly favorable of mRNA vaccines and testing in women. Both are all for full surveillance regarding the mRNA vaccines and the studies. And I'm pretty sure that they're going to be relevant in the coming future regarding that data. I don't know if you're still moving around or changing or whatnot, but in this first article that was pressed in the Washington Post, the title, you could go by the title, look, false claims tying coronavirus vaccine infertility to drive doubts among women of childbearing age. This was published on the 22nd at 9 a.m. in the morning. But from what you heard from the two doctors, what you think about how they feel about testing the virus? Yeah.
They said it was
Vaccinating.
okay. Oh, didn't they say they could vaccinate pregnant women? Did I hear right?
Yeah. Mm-hmm.
Yeah, it is what it is. The data. It's the data. You know, they say women don't. Yeah. Infertility and all that nonsense. It's nonsense. Like, I'm trying to figure out, like I said before you played it, where y'all get that from? Hell, like, how y'all come up with that? Like, like, how would you know? Like, it's only been a year, so it takes 9 months for a heavy baby. So how do you know? Right, but see, people not gonna think. See, we're thinkers over here. We thinking, bro. So if people been vaccinated, it ain't even been a year. Hold on, it ain't been a year. Yeah, it's the trials, right? Got to include the trials. So how long has it been? About a year, right?
Yeah, it's yeah.
Okay, and it takes 9 months to have a baby, right? So we need the data on that. Right, we need the data on people not being able to have children that's been vaccinated. There isn't any data on that. They doing the same thing the pseudo doctors did. The pseudo doctors was making up shit. Like, well, the ribosomes that type in the code, and they said it real slick, type that, it skips a type, it skips. Okay.
Yeah.
Is that not what it normally does in an unvaccinated body? Yeah, but in an unvaccinated body, it may cause cancer. Okay. So where's the data showing that a vaccinated person ribosomes mistypes more often than a non-vaccinated body? Well, they ain't doing that. It may see. Right. That's the point. So it skips probably the same amount as long as it don't do it more in a vaccinated person, then they not mad. Just like we did the Bell's palsy. It was 7 people, am I correct?
Yeah.
3 of them had been vaccinated and 4 had placebo, correct? Okay, so having 3 people out of 40,000 people, that means that the Bell palsy occurred at the same rate in the vaccinated population, in the non-vaccinated population. So it's not concerning. Now, if it was 20 people, then it would be a problem because now it's occurring more often in a quote unquote vaccinated population than it does in the regular population. So that ribosome skipping, typing, and all that, like, come on, man. So, but people got to know that. See, we just got to know, bro, that it just we know the literature, we understand it. Like, people aren't sending each other sources every day and reading it. Like, you send me a source, I'm reading it. You send me a video, I'm on it. You know what I'm saying? Like, they not. So we could never expect people to even remotely come close to it. Like we're asking for a lot, bro. And then it just takes a certain level of education. Now, it doesn't even have to be formal education; it just has to be education. And most people shy away. You know, we got a culture of shying away. So for people to understand it, hey man, like, it's been a year. Where's the data that show that the vaccine is going to make a person sterile? You got to ask for that. They don't have it. And they don't know how to say, well, we don't know yet. So, like, in that interview, they were simply saying, we just don't know. And see, science is counterintuitive. So for a person to say we don't know, we think that means that later on they won't know. Or we think that means they're trying to scam. No. Like in religion, you can't say I don't know. whether Jesus is going to help me or not. You got to say Jesus is going to help me. You just got to say it. You can't say it's not. So in science, it's counterintuitive because if we don't have the data, we don't have the data. When we do have the data, we do have the data. And I think the point that you made the other day, right, was to those pseudo doctors that in real time, right, we know how long the quote unquote natural antibodies last. So is that not what the conversation had fell upon? Wasn't that it?
Correct.
And they was trying to make it seem like that you was using like a personal friend or something like that. Like that was the only thing you said. Am I right or wrong?
Right. When I use something else,
Yo,
I
what
use
you
something
did?
else. I use something else, and then I also said, well, we can just take a look at Malcolm.
Right. What's the other thing you used? I want to get that right. What was the other thing
I
you used?
said the antibodies. I said people were. I said there's a repeated infection. People are catching COVID 2 and 3 times, and COVID. And this virus has only been circulating where we are for over a year, and
Okay.
you know, you had some people that has been infected 3 times in 1 year.
Mhm.
So think about that. They've been infected 3 times in 1 year. And then you got some people that's been infected 2 times in 1 year.
Mhm.
And this is with us even wearing masks and social distancing.
Mhm. 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 So, like, but they act like you didn't say none of that. They act like you was just trying to say about Malcolm. That's the point.
Right. He got mad at me because I rejected the notion of natural immunity as a part of the reason why something was doing so well. Like they were literally trying to say, well, really what they were trying to say is the vaccines aren't doing as well as they're propagating because of natural immunity.
Mm-hmm.
They were saying that they're not letting natural immunity take over because they're trying to vaccinate everybody.
So
Well,
they
if
re-
immunity was creating antibodies that was lasting for some period of time, why do we have reinfection?
Mm-hmm. Mm-hmm. Oh, that's when you was dumb. That's when it
Right.
turned left. Are you mad? Natural immunity. Like, are you mad? Yeah, that's when you got to be mad. That's when the name calling started, and that's when I was like, okay, you just threw your gun, sir. Yeah, I did throw my gun. Didn't he say that?
Yeah. He did. He
Yes.
agreed. He did throw his gun.
Yeah, yeah. I was like, wow, dude. Yeah, okay. Well, let me tell you something. You're lying about this. You're lying about that. You're lying about that. Yeah, and then we got off like we were supposed to because they was just lying at that point. And so, yeah, I knew I heard that conversation. Like, yep, they did not want to hear that the natural immunity. See, people don't want to hear that each virus affects the body differently, right? They're organism unto itself. Okay, so an AIDS virus is different. Those big spikes ain't sitting up on that AIDS virus where you can just replicate it real quick. Blah, blah, blah. It's hard. That should change, and it different spikes is different. Got a lot of different mechanics on that, but the coronavirus is perfect for us to work with. But they don't want to understand that. So the AIDS virus and the coronavirus is 2 different things, although it's
Yeah.
a virus. You know what
Yeah.
I'm saying?
Let me give you an update. I think we're leaning toward Sunday evening on that conversation I hit you up about.
Okay.
Also on the screen, in the Washington Post, they talked about the JAMA article where the lady was vaccinated at 36 weeks pregnant,
Mhm.
and she had the baby. And the study revealed that, you know what I'm saying, the baby was born 3 weeks later. Researchers detect antibodies in the cord blood. And a study in JAMA Pediatrics led by research at the CHOPS, which is, you know, one of your favorite sources, found antibodies in placentas from 72 out of 83 pregnant women who had previously been infected.
Infected with the coronavirus?
Uh-huh.
Huh?
Yep. They were infected.
And the antibodies went to the baby?
The antibodies was found in the placenta. I don't know about the antibodies in the baby. And
Like
if that's just from natural infection, then eventually that's going to run its course on the women's side, but we don't know for the baby.
Oh,
And
okay.
then
Yeah, that's what I'm
a nurse in Texas who's trying to start a family consulted with her fertility doctor before deciding to get the vaccine. She said the majority of her colleagues have said they are not getting the shots. And even her own parents are hesitant, but she came away from her own research convinced the vaccine is safe and was also pleased with the indication that if she got the vaccine, she might be able to pass on some immunity to her child. So that's what we're talking about right now. So that's the ending of the Washington Post article regarding
Wait. So it said the vaccinated mother will
Yeah.
the baby pass on some immunity to the baby?
Yeah, will be passed on some immunity to the baby. Yes.
Okay, yeah. Of course, breastfeeding and just period, right? Yeah, there you go. So they starting to do it now. I got you. So they gotta, yeah, man. Who was we talking to, Sean, about that? It was the crazy guy with the vitamin crazy guy that was on with Wuja last night. That guy. He came back.
I didn't see that, but I heard the guy was on there. So that dude came back again.
Yeah, he came back again, but he got beat up something crazy. Then he came back again with the fake book.
Oh man.
Yeah, that guy. But I'm just, who was we talking to about? They was like, oh, you can't vaccinate a mother with a baby. Why not? Something crazy, man. People, I mean, it's just, I don't know, bro. You know how long we've been talking about this shit, dude? I'm going to keep bringing it up. We done heard everything. We done heard, you know what we don't hear no more, though?
What?
We hear nobody talking about the mRNA vaccine. Like, it's going to make the shit mutate. They, like, ran away from that. They ran away from even there ain't shit in that. Ain't no chemicals in that. They ran away from that. They just be trying to talk about the second generation. It's just all over the place. It's the worst. It's the worst time of the year, bro, to be ignorant in North America. That's all I'm gonna say. I ain't gonna say ignorant and black, because people in general can be ignorant to subjects, yo. Black, but the black community, yo, and the blackity black who refuse to listen, the conscious community thing. Whoa. Yeah, I'm glad we building a scientifically literate community over here, yo. Yeah.
Yeah. So the whole notion of these trials and women and people being hesitant. I mean, I respect people being hesitant, but in your hesitancy, seek information to actually resolve that issue. Don't just be stuck. Because if you just stay stuck, then you're not really trying to find a resolve. You're just trying to find a defense mechanism. And then you're also to agree with that which does not fully answer your question. So I put all of these links in the chat for a combined reason. One, because the doctors are saying that it's okay. And they're saying it's okay because they're already bearing witness to people who have actually gotten vaccinated and pregnant, you know what I'm saying? Without even informing people that they were actually pregnant, or somewhere along in their pregnancy they wanted to get vaccinated. So it's like in the article written by the University of Alabama at Birmingham, they asked the question: is the COVID vaccine safe for women interested in getting pregnant? In a joint statement from leading women's reproductive professional organizations, the American College of Obstetricians and Gynecologists, the American Safety for Reproductive Medicine, and the Society of Maternal Fetal Medicine experts say, that's a lot of that's many different organizations right there, and they're saying this as experts in reproductive health, we continue to recommend that the vaccine be available to pregnant individuals. We also assure patients that there is no evidence that the vaccine can lead to loss of fertility. While fertility was not specifically studied in the clinical trials of the vaccine, no loss of fertility has been reported among trial participants or among the millions who have received the vaccine since their authorization, and no signs of infertility appear in animal studies. Uh-oh, they brought that back up, huh? That word, animal studies. So they are, like I said on the last show, they already have been studying infertility in animals. So this is how they're strong in their faith. And again, you got 54 million vaccinated people. I mean, my bad, 58 with almost 60 million people vaccinated right now. And ain't a loss of fertility going on. People getting pregnant. So the loss of fertility is scientifically unlikely. You see that? You hear that key word? Scientifically unlikely.
Sign. You hear me?
Yeah, I hear you now.
Scientifically unlikely.
Mm-hmm.
Mm-hmm. Now God might swoop into it, but scientifically ain't gonna happen. It's unlikely.
Right. It's unlikely. That's a strong stance from the obstetricians and gynecologists and the Society of Reproductive Medicine and the Society of Maternal Fetal Medicine. These people are the leads on all of this stuff. So we dealing with the experts, ladies. Your OBGYN people. We dealing with them, right? We're dealing with all these people that specialize in you being able to bring a child into this world and standing on the vaccine science. And we got the trials. That's why they feel so confident about let's go ahead and move forward, because it was already naturally happening. When you vaccinate 54 million people, do you not think that somebody's not having sex?
No, you got that wrong, Sean. First of all, people don't die. People stop dying when they take the vaccine trials. Nobody dies. People stop having sex once they get the vaccine, bro. Come on, man. What's wrong with you, Sean?
Oh, you're right.
Are you serious right now?
Yeah, I
don't
said
believe
that.
you, bro. Yeah, man. It's a vaccine trial, bro. Yeah, you messing up. It's a vaccine trial. Don't nothing happen. If you was gonna have a heart attack, that stop. All that. Nothing else gonna happen to you when you're in a vaccine trial. And once you get vaccinated, no more sex, no more nothing. Can't believe you playing with these people like that, man. Couldn't be possible for them to have sex and have a baby. Couldn't be. 60 million people, nobody's having sex. Nobody's getting pregnant. None of that. Yeah. White man. Yeah, dog. Yeah, let's just stay with the doctors, man. I want to stay having conversations with doctors, man. The good ones and the bad ones, bro. I think I'm giving up on that. Yeah, the pseudos ain't even fun no more. They ain't even ready, bro. Man.
Mm-hmm.
We need to remember that article we had on the vitamin D from the Lancet, yo. We need to vitamin D up and then zinc them up. Yeah, we gotta go to the Lancet and zinc them up. We had some pseudo doctors talking about zinc them up and vitamin D them up. It's crazy. It's crazy. Zinc them up. Yeah, I need to do some more research. I believe they selling some supplements, man.
Listen to what the experts say.
How much you want back? Want to make a bet?
No, I'm with you. But listen to the experts on this one. They said COVID infection is much more dangerous for pregnant women compared to women the same age who are not pregnant. If you get COVID while pregnant, you are much likely to be in the ICU on a ventilator with a higher risk of death. There's also a high risk of preterm birth and related complications. Knowing that the benefit of vaccination outweighs the potential risk of infection complications should give those contemplating pregnancy a sense of relief. We have the protection we need. It is important to encourage those who are healthy and eligible to become inoculated. They're telling you to get inoculated. They're telling you the risk of COVID infection is deadly and dangerous. Dang, Mika, you taking another L. She said pregnant women shouldn't get vaccinated.
Who said that?
Mika did.
Mika, why you say that, Mika? Hit the link, Mika. Mika,
Queen
hit the link. We wanna know why you saying it.
Queen
Sudo.
Sudo.
Curious. Why you think that? Huh?
She's just being Queen Sudo. She in the chat. Chatty
Mika,
Patty.
why you tell us why you say that? Just curious. Oh, you went Chatty Patty. You gotta hit the link, Mika. We wanna know why you think it's that. I think you got a right to think that. We just want to know why. Make us part of that process of understanding why you think.
Google Scholar says pseudo
What she
alert.
say?
Being
Pseudo
pregnant.
alert. Pseudo alert.
Yeah, man. Google Scholar let it be done. You did say that. All right, hold on. So let me go back.
She said she ain't said it.
No. Here we go. Pregnant people should not get vaccinated. She said that at the 9
Put
o'clock
it on the
hour.
screen, Sean. Put it on the screen. You can put it on the screen. Can't you put it on the screen?
Yeah. Hold up. I can put it on
A
the screen.
comment.
Yeah, I can. Hold up.
Put it on there. We're gonna see it. No, you can do it.
I got it right here. I'm gonna do this. Boom.
Pregnant people should not get vaccine. Oh man, we got you. We got her. She did say it. Now put it on there what she said she didn't say.
They put it on there.
Hold on, keep it right there. Hold on. See me on the screenshot. Wow. I'm gonna use the technology like the youngins say. We're gonna use technology. Post it on Facebook. Man, put it on there what she said. And then get the one where she said she didn't say it. Let's see.
All right, let me find it. Hold up.
Let's see.
She might have erased it. Oh, there you go. Boom.
All right, boom. Hold that. Bam. Got it. Technology. Got it.
Look, get this one too.
Smiling faces. Smiling faces. Got it. All right, what you got?
She said it wasn't her.
It wasn't me. Bang, hold on. I got it. Bow. Got it. We got you. I'm gonna put you on Facebook.
She got beat up. I know. He said the pseudo alert was not for Mika. We all know she's pseudo. So we already went over the Pfizer and BioNTech's global clinical trial to elevate COVID-19 vaccine in pregnant women, right? They published that on the website on the 18th. They also have a clinicaltrials.gov identifier, which is NCT. I'm putting in the chat. I don't know if y'all know how to look up clinicaltrials.gov, but that's the clinical trial number right there, NCT04, right here. NCT04754594. You can go to clinicaltrials.gov. You can put in that number right there, and it'll pull up the Pfizer and BioNTech's global trial regarding that. So yeah, there you go right there. Now, I put another article in there and that I want to put on the screen real quick because this lady had recently took a different position prior to the latest news on this testing for pregnancies. Now, it says, wondering about COVID-19 vaccines if you're pregnant or breastfeeding. She posted it on January 7th. She updated on the 17th once news broke. So this doctor, who's a contributor, she just pretty much updated her article regarding the mRNA vaccines, and she answered some specific questions. So you can read more about pregnancy and COVID-19 here. And she did a good job updating her information because science is self-correcting, and she allowed the data to rule the conversation. So, the bottom line, COVID-19 vaccine for people who are pregnant or breastfeeding has potential benefits and raises some as yet unanswered questions. It helps to become as informed as you can in making a decision, but realize that information may be changing rapidly. We will be learning more about COVID vaccine safety during pregnancy and while breastfeeding from animal studies, animal studies, which they know now are underway, and from human studies that are enrolling participants. Right. So here we go again. We back at a year ago. And what we're basically doing right now is we're about to run concurrent trials. Again, right now they already got the animal stuff going, but they are about to do the whole human trial thing too. And that's the beauty of science. Yep. Shares me on the chat out.
Huh?
Shares me on the chat.
Who in the chat?
Shares move.
Shares move. Batar Shares move.
Yep.
Now, what are you talking crazy? What Shares move?
Always.
Shares move crazy, Shares. Shares crazy. He must have stopped studying or something.
He did. He had to, bro.
Hey, fellow. Yo went right while wearing pseudo rope.
He became an Aboriginal Moor, remember? That don't require studying.
He did what? What did he do?
He became an Aboriginal Moor. That don't require studying.
Did he?
Yeah. Facts.
Shares move. Oh wow. Yeah, he bugged out. Yeah, Shaz, you science over here, bro. You know, Shaz a reverend though. He's a reverend. He's a rev. Forgot. Ask him. Hey Shaz, when you a reverend, a rev, yo?
Mm-hmm.
Yeah. What'd he say? Yeah? What'd he say?
I don't know what he said. He ain't said nothing yet.
Yeah, he was a preacher, yo.
Pseudo.
Oh man. Oh man. Man, oh man, oh man. Man, what they gonna do?
Mm-hmm. So yeah, that's where we are. So everybody get ready to enjoy the new wave or the new ride and the new studies. Like we dealing with methodology in real time. We're gonna walk through the results as the data becomes available. Right now we're waiting on the FDA to make a final decision on Johnson & Johnson. I really would like, that's what I need to do. Dr. Hildreth. I need to get Dr. Hildreth on the screen. He had an interview that I wanted to kind of put on the screen.
All right, Sean, I gotta get out of here, man.
All right.
That's my bedtime, man. Appreciate you, man. I'm gonna go back and hit the rewind, man.
Okay.
All right. Peace out.
I wanted to see if I can get this on the screen. Hold on, y'all. Just bear with me. I always want to hear from Dr. Hildreth. Because not only is he on the FDA board, but he's in the White House now. You know what I'm saying? He's in the White House. White House advisory team, yo. So let me put this on the screen for everybody. And due to the Fair Use Act, we're going to run it. We're going to run it for the Fair Use Act. And You back on?
Yeah, hey Sean.
Yo.
Shesmu say somebody blocked him off the chat, yo. He say
Nah,
Nile Valley blocked him on chat.
he's talking right now. I ain't even thinking about him. He said some old stupid stuff. Hey, I'm finna play the Black Doctor, Hildred.
Wait, he was actually blocked out the chat though?
Nah, he wasn't blocked out the chat.
Oh man, really, yo? Come on, Shez, yo. God, man, get off it, man. Lying and shit. All right. Go ahead, play it. I'm listening.
All right, yeah. So he had an actual interview, Fauci. It's more long, but I'm not gonna play all of it, y'all. They got music and all that stuff, so.
Stand by before we begin with a word from Planning Committee member Ralph Fruccello with Cambridge Concord Associates.
Health needs of people in underserved communities, but COVID brought racial and ethnic health disparities to the mainstream media in a more pronounced.
I'm James Hildreth, the president of Meharry Medical College, and I'm pleased to host this conversation with my colleague and the nation's top infectious disease doctor. Really happy to see Tony again. So Tony, welcome.
Thank you, Jim. Good to be with you.
Yes, and congratulations on winning the Israeli Prize for speaking truth to power. I was so pleased to see you get that award.
Thank you. Thank you. Appreciate it.
And speaking about truth and power, one of the things that we've been focusing on is trying to use truth and facts to improve the uptake of vaccines. And I wonder if you could speak to how you've been trying to do that to make sure that people understand the factual information about vaccines, help us get people to take the vaccines. If you could speak about that, that would be great.
Yeah, sure. Well, Jim, that, it really depends on what group you're talking about. I've put, as you probably know, a considerable amount of effort into addressing the African-American community, both in churches and in African-American organizations.
Yes.
The issue with a vaccine of the typical anti-vaxxers or vaccine hesitancy is a different issue than what's seen in the African-American population. And let me spend a minute or so on that because I really think it's important.
Okay.
The hesitancy that we see in the African Americans really relates to something that we need to deal with. It's an extraordinary, unfortunate history that African Americans have been subjected to under federal programs that related to health issues. And we all go back to the decades-old situation with the Tuskegee experiments, which were egregious violation of ethical principles. Now, most of the African Americans today were not even born in the decades ago when Tuskegee took place.
Yes,
but
right.
The story of that gets handed down appropriately from generation to generation as one of more than just a single one of the incidences of how African Americans were not treated with ethical consideration by the federal government. And so the first thing that I do is that when I encounter people who have hesitancy or reluctance based on the history that was probably told to them by their grandparents and their parents, is you have to respect that hesitancy.
Yes.
And don't blow it off and
Yes.
say, oh, that was just a long time ago. Why are you bothering with that? No, you have to say, and I do, that you respect it because it was real and it was something that you just can't put aside as if it didn't happen. However, the next thing you do is to say, as I do, that since that time, there have been ethical constraints and guidelines that have been put into place that would make something like that today impossible to happen. You're very familiar with them, I know, Jim. When you have institutional review boards and data and safety monitoring boards and a whole variety of committees that are independent of outside influences,
Right.
that actually allow one to go ahead with confidence. Once you put that behind you, you can say, okay, now that we've put that aside for a moment, what are the reasons why you're hesitant? the number one reason is, boy, this happened too fast. You must have done something wrong.
Yes.
We know that vaccines take years to develop. And we know that this virus was only recognized in January of 2020. And in less than a year, you're putting vaccine into people's arms. How can we be sure that this is just another thing that would essentially endanger our safety?
Right.
And the answer is that it is not compromising ethics. It's not compromising safety. It's merely a reflection of the extraordinary advances in the science of vaccine platform technology. Anyway, that's a good start.
Well, so Tony, I don't think most people understand that you're uniquely qualified to speak about the science, because for decades you've been dealing with HIV, Zika, Ebola, and all of this. So if anyone could speak to the science behind this, it's you. And so I really appreciate that. One of the things that we're also concerned about, as you know, is the disparity and the effects of COVID-19 on different populations in our country. And I just wondered if you have some thoughts you could share about how the Biden administration and the other agencies of the government are dealing with that.
Yeah, well, one of the sad facts about COVID-19 is that it has shed a very bright light on the health disparities that have been experienced by minority populations, Black and brown people, for a very long period of time. That every once in a while, when you get a very dramatic situation that we're in right now, you realize it. For example, African Americans and Hispanics have a higher incidence of COVID-19 merely because of the jobs that they find themselves in, which are usually out in the community doing essential services, to
Right.
put them at risk for exposure.
Right.
That's point number one. Point number two is that because of the social determinants of health that they've had to deal with since birth, because of economic situations, the lack of accessibility to health care, the lack of a good dietary framework from the time that they were children, put them at a higher risk of having the underlying comorbidities that lead to a more serious outcome if, in fact, you do get infected with SARS-CoV-2, which leads to some startling statistics that the number of hospitalizations per 100,000 people with COVID among African Americans is multiple-fold greater than whites. The number of deaths per 100,000 is 2 or 3-fold greater than in whites. So you're having a very serious situation. How do you deal with it? Well, you deal with it in the immediate term, and you make some commitments for the long term. The immediate term is to immediately have things like testing and availability and access to healthcare among African American populations. The other is to make vaccines accessible to them, because if you let things be business as usual, African Americans and Hispanics, when it comes to accessibility of things that have to do with healthcare, they are not going to be as available to them as to other people. So what the Biden administration has done is a couple of things. First of all, with regard to vaccinations, created community vaccine centers that will be located deliberately in areas that are demographically representative of the African American and Hispanic population. 2, get vaccines to pharmacies, again, that would be located in areas that would be accessible. And 3, using mobile units to actually go into not easily accessible areas. And then finally, what the administration has done is to create an equities task force. And it's headed by an African American physician named Marcella Nunez Smith, whose responsibility is to make sure that these inequities do not occur in our effort to get people treated, tested, and vaccinated for COVID-19.
And so, and Tony, I'm pleased to be on that task force with Dr. Nunez Smith. Looking forward to that work. One of the narratives that's starting to develop is that the J&J vaccine, if it gets approved, has a less stringent storage condition. So people are proposing that that might be better to get into disadvantaged communities, but it has a lower efficacy than, of course, Moderna and Pfizer do. So how do we avoid having the perception take hold that the disadvantaged populations are getting an inferior vaccine? Because that would be the last thing that we want to see happen.
Yeah.
About that?
Yeah, that's going to be a tough messaging problem. And that's the reason why we got to be very careful. So what you're referring to for the listeners is that the Moderna and the Pfizer vaccine against mild to moderate disease is 94 to 95% effective. The J&J against, in general, mild to moderate disease is 72% effective. However, when you look at its efficacy against severe disease, it's very good.
Yes.
In fact, if you look at the people who wind up going to the hospital and dying, you almost don't see any of it with that, which means that if you want to protect against really getting sick, then the J&J vaccine is definitely value added. And I would say that if you were able to get a vaccine right now versus a J&J right now versus waiting a month or two to get the other vaccine, I would go for the one that I could get right now.
I agree, and that's kind of what I've been espousing to the people that I speak with. So, but how do we begin to make sure that people understand this, Tony? Because, you know, a lot of people have been calling me, asking me, why are you pushing this inferior vaccine on us when there's a better vaccine out there? And, you know, how do you deal with that? What is the approach?
You know, as I said, Jim, it's a messaging problem. Right. But I think the first thing we've got to do is get rid of the word inferior. It is not an inferior vaccine. It is a really good vaccine, and it's getting evaluated now by the Food and Drug Administration. And on February 26th, they're going to probably put it before their advisory committee. I think we just need to be hammering home the message that it is not inferior. It is a value-added vaccine.
Well, I agree with you, and we have to find ways to make sure people understand that. Another one of the issues that's related to that, I suppose, is, and again, you're the best person to ask this question to, should we be concerned that the one shot is going to give the same kind of durable immunity we expect to get from the other vaccines? Or do you have any thoughts about that?
Yeah, I mean, if you look at the clinical trial, we will be following the people who are in the trial to show the efficacy of the J&J for 2 years. So we're going to know what the durability is. Quite frankly, Jim, we don't know what the durability is of the prime boost of the Moderna and the Pfizer. So it isn't as if we know the answer to one, but we don't know the answer to the other. The other thing that I think people should be aware of is that there's a clinical trial going on right now to take a look at what happens if you give a boost to the J&J.
Right.
So we'll be able to compare a single dose with a prime boost, and we'll get the answer to your question.
So Tony, one of the things that I sort of imagine out loud is that if you're infected and recovered, that could constitute a prime against the virus. And then maybe a single shot with a vaccine might put you in good stead for lasting immunity. You have any thoughts about that?
You know, I have some thoughts about that, Jim, based on data that I didn't collect, but that has recently been collected, and it's really impressive. So if you were previously infected and then vaccinated with a single dose, and compare the level of neutralizing antibodies compared to someone who wasn't infected but received a prime followed by a boost. The person who was infected followed by a single dose of vaccine had a dramatically greater and better response than someone who had a prime followed by a boost of the vaccine, which is interesting data, which means that if you're going to be vaccinating people who are already infected, you likely could save a number of doses by only requiring a single dose.
Right. Well, that's good news, and I think that's going to make the vaccines go a lot further. And I would have imagined that would be the case. You know, this conference is all about oral health as essential to overall health, and one of the things we're talking about is interprofessional training and how the professions can work together. So, one related question to that is: do you think it might be advisable for us to train dentists and other non-physicians to give the vaccines to expand the number of people? Because we're going to have to give these millions and millions of shots. So you think it'd be advisable for us to look at training some others to give the vaccines?
Oh, I think it was not only advisable, I think it should be recommended. Absolutely, because, you know, one of the things actually that the president himself at the town hall meeting last night mentioned, that we have a number of things that we need to catch up on. We have a greater demand than there is a supply of vaccine, and we don't have enough vaccinators, people who are actually sticking the needle in people's arms. So if you're going to get dentists and dental students and oral hygienists and those who are involved in the dental profession, if you could get them involved in helping to administer vaccines, I would think that would be a big boon.
Well, I agree, and we look forward to being able to do that here in Marion in Tennessee. One question I must ask you, because it's something really important for me, is from my perspective, we took a population approach to dealing with COVID-19 that assumed everybody had the same level of risk, Tony, but we know that they don't. And I thought a more focused approach should have been what we took to dealing with the pandemic. Do you think there are some lessons we might have already learned about this situation, the past administration notwithstanding, that'll make us in better shape to deal with the next pandemic? Because I think there's going to be another one. You have some thoughts about that?
Yeah, I know it gets back to what I mentioned a moment ago, Jim. The issue of health disparities just keeps coming up. The susceptibility to infection and the availability of care, access to care, is so dramatically different. Then I just think we need to fix those disparities. The trouble is, as you well know better than I, you don't do that overnight. You have to have a decades-long commitment to do it. So I think that this experience that we are going through right now with COVID-19 is so historic in its proportions. I mean, it's essentially immobilized the world for a year. I mean, I've been through a lot of infectious diseases, crises. I've never, nor have you, been through one where you've immobilized the world for a year. So I think that that's something that is so serious and so impactful that I hope it allows us to have a strong enough corporate memory that we don't forget the lessons that we could have learned, that we should learn, and hopefully will have learned from this experience.
And I guess the other thing that relates to my first comment to you about speaking truth to power, is there some way we can ensure that the FDA and the CDC, which are the premier institutions of their kind in the world, they don't get hamstrung by politics again? I know this may be not, but that's appears to me what happened. We have these two amazing organizations, and for reasons not of their own making, they were not able to do what they normally do, which is to respond to a crisis. So how do we avoid that going forward?
Well, I think what we do is we remain acutely aware that it can happen. Mm-hmm. And we need to keep an eye out on it. And everyone in and out of government have got to be committed to never allow organizations that should be completely free of any political influence to have any political influence. So, you know, we've been there, done that, don't ever want it to happen again.
Well, and I guess to that end, one of the themes that President Biden, and correctly so, has espoused as being one of his goals is unity, right? And I think unity in our response to this pandemic might have served us well, but what does that look like, and how can we achieve it going forward? I mean, from your perspective.
Well, from my perspective, having gone through the past year, the one thing that was so counterproductive is a mild word, Jim, to actually address a common enemy, which is a virus,
Right.
which is devastating the world and devastating our own country, causing economic, social, mental, and other disruptions, is to not being pulling together and rowing in the same direction. The worst thing that could have happened is that we had a public health crisis in the middle of a very divisive country.
Mm-hmm.
You don't need me or anybody. All you need to do is to have observed what has happened over the past year, how divisive things were, where you had things that should have been purely in the realm of public health,
Right.
like whether or not to wear a mask, or whether or not to avoid congregate settings, whether or not to hang out in bars when you know that's super spreading places that
Right.
will lead to infection. The fact that there's even an argument about that tells us that we're really not pulling in the same direction. I mean, I've had situations, Jim, that stunned me, where you have certain regions of the country where you have the hospital system being almost overwhelmed with the number of people, where you have a hospital that has 20 intensive care unit beds and 50 patients who need intensive care. And in that same state or city or town, you have people who think it's a hoax, who
Right.
saying it's fake news. I
Right.
mean, how could you possibly have such an extraordinary denial of reality? So those are the kind of things, hopefully, we don't have again, where divisiveness in a country, political or otherwise, leads to interfering with an optimal response in a public health arena.
And so, Tony, one of the other things that I just want you to comment on is that a pandemic is by definition a global epidemic, and this virus, unless it's dealt with around the whole globe, we'll be dealing with it in the future. So you have some thoughts about how we make sure that all the people who need the vaccines will get them?
Well, absolutely. I mean, that's a critical issue. I mean, obviously, you need to be concerned primarily about your own country. You want to take care of and protect your citizens. But as you well know, Jim, we live in a global community, and a pandemic, by its very definition, pan, which means all.
Yes.
I mean, a pandemic means the entire world.
Right.
And even if we get this epidemic in our own country as part of a broader pandemic, even if we get it under control and we vaccinate the vast majority of the people in the country, the fact is, if we have a roaring pandemic outside of our own country and we don't contribute to controlling it, we will continually be threatened by variants and mutants that come from another country into our country and rekindle yet again another outbreak in our own country. And that's the reason why I was so pleased that we've re-entered the the WHO. We're back in the WHO. We've promised that we will pay our back dues that we need to pay. And importantly, we're joining COVAX, which, as you know, is the consortia of organizations that are going to try to make sure that underdeveloped or middle and low income countries have the capability of getting vaccinated and responding in an appropriate way to the outbreak.
So Tony, I know your career spanned quite a long time. Certainly has overlapped mine, which is now 40 years. And I want to thank you for all the people that you've inspired to do the work that they do, because I'm included in that number. And for all the budding young scientists out there who might be thinking about research in medicine, do you have any closing thoughts to offer to them?
Yeah, I mean, I think it's something that you and I both share. I mean, the excitement and the gratification of a career in science, particularly biomedical science, medicine in general, global health, as an offshoot of medicine in general. If it's something that suits you and you're a young person who's thinking about a career in medicine and public health, I think there's hardly anything that can be more gratifying and more a feeling of an accomplishment than getting involved in helping to save people's lives. I mean, I don't want to sound too dramatic, but it's the truth, as well as to enhance the health not only of your own country, but of the entire world. So that's the reason why when I see young people now looking at what's happening and get really excited about the possibility of getting involved in this field, I can only cheer them on and say, you won't regret it if you do.
Well, I mean, I totally agree. And I know that you have to leave us pretty soon, but I do want to thank you for all that you're doing for the country, actually for the whole world, and for all the people you're inspiring, and for speaking truth to power. Thank goodness you're still there. We're all just so happy that you're still there. But for all that you do, Tony, really thank you so much, and we appreciate it.
Thank you very much, Jim.
Okay, all right.
Take care.
So with that, I'd like to thank Dean Farmer Dixon, the Planning Committee, and the sponsors of this conversation. And with that, I'd like to turn this back over to Dr. Celeste Stein, who's going to introduce the moderators and the panel members. Thank you.
All right, so I wanted to get that out the way and deal with, just putting Dr. Hilger's face on the screen while he's interviewing Fauci. That's always good stuff, right? So on that note, man, I'm not gonna hold everybody else up, man. I'm checking the chat, see if there's anything interesting, but it doesn't look like it. We've been on for about an hour and 45, so I want to kind of keep it bite-sized. And, I appreciate everybody tuning in. Catch the replay on that note. Y'all already know what it is. Simran Hotel.
Log in to KofiPaisaTV.com and get Spears of the Mossy Volume 1 by Kofi Paisa Research Team, from Spears the Pen Volume 2 by Kofi Paisa Research Team, Spiritual Combat Volume 3 by Kofi Paisa Research Team, One Night Before Bed by Any Harret Sean Calfunny, Kalawa's Trip to the Motherland by Kofi Paisa, From Cocaine to Consciousness by Any Harret Sean Calfunny, As I Learned, We All Learn by Kofi Paisa. Also, if you want fresh merch, go to our online store, Family Connect Apparel, and get all the brands. Also, get our 54 deck of quiz and educational cards available now on KofiPaisaTV.com.